All right, this is part 2 of the cervical and thoracic spine assessment, and we're going to pick up with our pathologies and the special tests that we would use to evaluate for those pathologies. Brachial plexus pathology then is the first one we'll talk about. So this is known as a burner or stinger. It can be caused either by a traction injury or by an impingement injury, meaning that the patient may complain that the cervical spine was flexed to the left side and the pain may be on the left side, in which case you're probably talking about an impingement type of an injury. However, if the pain is on the left side and the cervical spine was flexed forcibly to the right side, you're probably talking about a traction injury. I expect that you learned this in your upper extremity evaluation class, but because the brachial plexus is kind of in that space that is connected both to the cervical spine and to the shoulder, we're going to review it here. The patient would be point tender, perhaps at Erb's point, which is superior to the clavicle and anterior to the upper trapezius, and it is the most superficial portion of the brachial plexus. So you'd want to palpate in that area for sure. All right, so on your brachial plexus trauma, again, it's usually an acute injury. This person is going to experience paresthesia along probably the whole upper extremity. And the mechanism, again, could be lateral bending and depression of the opposite shoulder. So lateral bend to the right, depression of the left shoulder. Could also be lateral bend to the strictly lateral bend to the left side. That would be more of the compression injury. And along with that, the patient may also extend the cervical spine as far as included in that mechanism. Their grip strength is typically diminished and there's no voluntary motion of the arm initially, but we know with our brachial plexus injury that it tends to resolve very quickly. So one thing that you want to be able to do is differentiate between a cervical nerve root impingement and a brachial plexus injury. So the brachial plexus injury by its nature is transient. The person is going to begin to resolve, the symptoms begin to resolve, within minutes, at least within an hour. Some patients can actually experience this brachial plexus injury and return to play the same day. So you would evaluate this by asking them to squeeze your hand. They're going to have trouble doing that with the involved arm. The posture will be one of the big giveaways. It's going to be hanging limply at the side. Your initial diagnosis or differential diagnosis just on examination on the field could possibly also be a shoulder dislocation just because of the patient's posture. All right, so you definitely want to palpate the cervical spine for the possibility of a fracture or dislocation, and there could be on palpation also, again, tenderness over Erb's point. Stability tests we would not do. Again, return of motor function usually begins within minutes after the injury occurs. Okay, we want to do the brachial plexus stretch test to diagnose this, cervical compression and distraction to rule out a cervical injury, as well as Sperling's test. All right, we would also do a complete upper quarter screen because we want to make sure that there hasn't been any residual nerve root deficiency and or problems with the peripheral nerves. All right, this patient does not necessarily need to be referred. And another thing to keep in mind, if they have a positive history of a brachial plexus injury, then it may take them longer to recover when they have subsequent injury. So you might have to treat them more conservatively. All right, so this is an example of the compression and the traction, or an illustration rather, of the two mechanisms for brachial plexus injury. It is very common in tackle sports, so rugby, possibly men's lacrosse, even though that's not truly a tackle sport, and also, of course, football. Okay, so here's our brachial plexus traction test. In this diagram here, the tension force is being given to the patient's left side. If they experience pain on the right side, then that would be considered possibly a nerve root involvement or possibly a compression type of an injury to the brachial plexus. So it could be either or. All right, so then I was mentioning nerve root compression. And the thing about a nerve root compression is that the patient would have neurological symptoms along one or more dermatomes and myotomes, and that would not resolve. So again, the brachial plexus tends to resolve somewhat quickly, motor function returns, et cetera, but that is not true of the cervical nerve root compression. Okay, so the timing of it and the symptoms being in the dermatome myotome pattern for the cervical nerve root impingement would be some of the key characteristics that would distinguish brachial plexus from nerve root impingement. Another thing to consider is the thoracic outlet syndrome. Again, it's kind of in that space that is between the cervical spine and the shoulder. We can have three types of thoracic outlet syndrome: vascular, neurogenic, and nonspecific. What's happening is that there's pressure, especially on the trunks in the brachial plexus, on the medial cord, the subclavian artery, or the subclavian vein. Because there is circulatory involvement here, the patient may complain of numbness, tingling, as well as swelling. The skin may be pale, may be cold, depending on the type of the injury. So the management consists of correcting the posture. I've had good success using the Blackburn exercises, where we do a lot of scapular stabilizing and correcting the patient's forward head and rounded shoulder posture, as well as in terms of correct muscle testing. Again, the muscles of the scapula are going to be key. You're going to need to strengthen those in order to correct this problem. All right, so here's our examination findings for thoracic outlet syndrome. I'll let you read through those. Again, you all have already learned this, so I'm not going to read it to you again. Okay, so for our class, I will not be testing you on Allen, Adson's, and Roux. That's tests that we've already done, and we really don't have time to go back over them. So I just want you to be aware of this pathology. It will be part of your written exam, but not part of your practical. Again, you've already been tested on this. Okay, so here's Adson's. Again, we're not doing it. And Allen's, and military brace. Okay, so this is a good review of things that you've already learned. Here's Roux test. Okay, all of those are trying to reproduce the symptoms that the patient is experiencing. All right, and our on-the-field management for the brachial plexus injury is probably the thing we need to be the most concerned about with our cervical spine injuries, other than a catastrophic injury, which we have already been over. And you all have perhaps seen this before. The athlete runs off the field on their own. The involved arm is dangling at their side. And again, the symptoms are typically transient. You want to rule out cervical trauma, perhaps apply some ice to it, and there are return to play criteria that would allow that patient to continue participation. They would have to have a normal neuro exam without weakness and have full pain-free range of motion. So with this, I would also incorporate probably some push-ups and some blocking or some sort of functional activity to make sure that they are able to complete it. All right, so this concludes then our cervical and thoracic spine unit.